All right, let's jump right in. We're tackling two metabolic firestorms that you absolutely have to nail for your boards, DKA and HHS. These are high stakes, so precision is everything.
Listen up. This is your mission-critical briefing. These two emergencies, they're all over your board exams, and there's just no room for error. So let's get into it.
Okay, check this out. On one hand, you've got DKA. Think of it as a ketone disaster. We're talking type 1 diabetes, it comes on fast, and you've got this massive anion gap acidosis just screaming for insulin. Now, on the other hand, there's HHS. This one's a dehydration disaster. It's usually your type 2 patient, sugars are through the roof, over 600, and that causes this crazy osmotic diuresis, leaving them severely dehydrated. That's what's causing that altered mental status. So how do we manage this? It's a 3-step attack. And listen, the order is absolutely non-negotiable. First, you hit them with fluids. Second, you deal with the potassium. And only then, only then, do you even think about insulin.
Okay, if you remember one thing, let it be this. This is the golden rule, you gotta burn it into your brain. Never, ever start insulin if the potassium is below 3.3. Why? Because you will trigger a fatal cardiac arrest. You have to get a handle on this potassium shift before insulin is even on the table.
All right, before we go any deeper, let's cover the rules of engagement. Okay, just a quick but super important note. This is our mandatory international medical disclaimer. Everything we're talking about here is purely for educational purposes, aimed at helping you prep for exams like the USMLE and PLAB. This is not medical advice. For actual clinical decisions, you always consult official guidelines and your hospital's emergency protocols. Got it? Good. Okay, let's move on. We're about to decode one of the sneakiest diagnostic traps you're ever going to face. I call it the potassium liar. So picture this. It's a classic board question. You've got a DKA patient, labs are back, and the serum potassium is 5.2. Your intern, all eager, wants to slam an insulin drip on right away. The potassium is high, right? So what's your move? The right answer? You stop that intern in their tracks. You tell them they are looking at a liar. That 5.2, it might just be one of the most deceptive numbers in all of emergency medicine. So what's the deal here? Well, here's the thing about DKA. That potassium lab value, it's a total lie. It looks high on paper, but the patient's total body potassium is actually dangerously low. See, the acidosis forces potassium to shift out of the cells and into the blood. That's what gives you that fake high number. And this is the deadly chain reaction that happens. First, the acidosis pushes K+ out of the cells, so your serum lab value looks high. But the second you start that insulin, it reverses the whole process. All that potassium rushes right back into the cells, the serum level just tanks, and boom, you've got a lethal arrhythmia on your hands.
So the key takeaway here is huge. We have to treat the future crash, not the present lie. You're not treating the number on the lab sheet right now, you're anticipating the crash that's coming an hour from now.
And this is the hard and fast rule. It is non-negotiable. If that K+ is less than 3.3, you stop. All thoughts of insulin go out the window. You give potassium first. End of story. All right, you've dodged the potassium liar. Now for the next big one. Let's disarm the anion gap trap. Oh man, the board examiners love this trap. It's called the normalization trap. And trust me, it's designed specifically to catch you off guard and make you fail. So here's how they get you. The patient's glucose starts to look good, maybe it drops down to 200. It's so tempting to just stop the insulin drip, right? Wrong. That's the trap. That's a fail. You do not stop the insulin drip until that anion gap is closed. And why is that so important? Because remember, you're not just treating the hyperglycemia, you're treating the ketoacidosis. Your real goal, your true endpoint, is resolving that acidosis. And how do you measure that? The anion gap. So, you're in that exact situation. Glucose is down to 200, looks great, but the anion gap, still wide open. What's the play? What do you do next? Here's the correct move. You add dextrose, something like D5W, to the IV fluids. This is brilliant because it prevents the patient from getting hypoglycemic, but it lets you keep that critical insulin drip running. And you keep it running until that gap is finally closed. Okay, let's lock this down. Time for the STORM matrix drill. I'm going to hit you with rapid-fire questions. You should have the rapid-fire answers. Ready? Let's go.
The hallmark of DKA?
Anion gap acidosis and ketones. That's it. Okay, next. Glucose hits 200, but the gap's still open. What do?
You add dextrose and you keep that insulin drip running. All right, high stakes question. What's the most common cause of death in children with DKA? Cerebral edema. You have to know this. It happens when you drop the osmolality way too fast with your IV fluids. It's an absolutely critical and deadly complication you have to prevent. All right, let's debrief the mission.
The metabolic storm has been stabilized. Mission E4.4 is secured. You now have the core tactics you need to manage these crises.
But here's the real question. Can you take all these individual pieces, the diagnosis, the pharmacology, the ICU management, and weave them all together into one single, flawless decision tree when the pressure is on? Because look, you're not truly ready for that final board challenge until you can do just that. You need to watch the Series E 4.5 Diabetes Master Finale. That's your next target.